So, hi there, everyone. Thank you for being here to hopefully not bore you too much. So, there are a lot of cardiac conditions for which genetics have really quite a strong influence. So, what we've got here, we've got coronary artery disease, cardiomyopathies, channelopathies, and the aortopathies. I am not going to talk about congenital heart disease because really that is never going to come into the sort of preventative type of panel. So we have a number of genes that we have put into this panel, some which actually are very rare and really are not going to really come into the agenda very much, but others which really are very important. And we've included probably more than maybe absolutely essential at this previous time. And I'll talk a little bit why that may be good or bad as we go through the presentation. So we've also got a sort of smaller panel which is associated with hypercholesterolemia, because obviously that is really, when we're talking about coronary artery disease, such an important part of cardiac problems. But I'm really interested. I work at both the Brompton and at St George's, and a sudden cardiac death, it plays a really quite an important part of my practice. At St George's, we have the professor of CRI, cardiac risk in the young. And so we see a huge number of tragic deaths. And, of course, everybody dies when their heart stops. So it is involved with everybody's death. But actually, sudden cardiac arrest accounts for about 36% of all deaths in America. So, it's the primary cause. So it is important to think about what is actually going on. Now, of course, the younger you are, the bigger influence of something like congenital heart disease that we will see. But actually, even when you get to 26 to 34, hypercholesterolemia and ischemic heart disease becomes to be a very significant part of the cause of sudden death. So you really do need to have the spectrum of in investigations. So hypertrophic cardiomyopathy here. Hypertrophic cardiomyopathy probably has its maximum influence in the teenage years as a proportion of sudden death, but it continues really throughout life to be one of the important causes of sudden death. Now, one of the problems that we have, and this is the cause of death in athletes in America, and here it is, it's saying hypertrophic cardiomyopathy is the most important cause. I think that in our particular series, we would have no cause found on death, but it's the easiest diagnosis that you can actually make. Now, channelopathies, remember, once someone has died, you've got no evidence whatsoever that that is the underlying cause. And that's why we spend quite a lot of time at St George's looking at molecular autopsies. And that's where we look at 150 genes to look for the underlying cause of those patients' death. But alongside that, we always investigate the first degree family relatives. I just would like to point out anomalous coronary arteries and their insertion, because this will be missed by every single test that we undertake in the screening arena, except probably a cardiac MRI. But, I think we have to accept there doesn't seem to be a genetic contribution to this, but it is something, unfortunately, we can't do anything about at the present time. So, when we look at how many people have had warning signs when they die suddenly, there is up to half of people who collapse that have had no warning sign at all. Now, of course, that says 50% have had a warning sign. And yes, of course, we should respond when people faint. and people have unusual symptoms. And when I look back on some of the patients that I see, you think, oh, if only they'd come forward at that particular time. But I think this particular genetic investigation sort of stopped some of the neurosis potentially that you have if you were investigating every single person who fainted and you were investigating them at that stage, because most people in their lives have fainted once or twice. So, well, if we start with something like coronary artery disease, now I have really not a lot to do with coronary artery disease, because that, in fact, all the genetics in the NHS goes through the lipid clinics. So I'm afraid this isn't any expertise. But hypercholesterolemia, approximately 1 in 500 people at least are heterozygote for the low density lipoprotein receptor mutation, which is by far and away the commonest cause. But we know that there are many, many modifier genes. And for those of you who joined last week, we talked about polygenic risk scores. And this is one of the tests that you would get in this preventative panel. You'd get a polygenic risk score of your risk of hypercholesterolemia. Now, we know there are modifier genes which we are actually looking at, but there are also other forms of monogenic forms of hypercholesterolemia. And the reason these are very exciting is because of some of the treatments that have now been started. So PCSK9 is a gene which causes really pretty severe hypercholesterolemia and is a monogenic cause. And I've put this little sort of just little square here because in PCSK9 mutations that cause hypercholesterolemia, those are what we call gain of function mutations. So they are causing too much absorption of cholesterol, because this is attaching to the LDL receptor and it's stimulating absorption. So if you've got something that causes a stimulation of absorption, if you switched off that gene, you could potentially improve hypercholesterolemia. And my goodness me, there are some very exciting treatments now. There's inclisiran that was given NICE approval in 2021. And a few years before that, there is alirocumab, which I'm afraid these are drugs that I never, ever personally use, and nivolumab, which are biological drugs, and they work in completely different ways. So PCSK2 inhibitor inclisiran actually works by something we call RNA interference, so that the drug actually attaches to the RNA itself and switches off the drug. So that's one way, and the other is an antibody drug. So these are really, really novel, very exciting drugs. And we know other genetic influences, including hypertension, diabetes, and obesity, play into coronary artery disease, but they are certainly not part of this talk. And actually, the genetics of all three are a bit of a nightmare. So I have no intention of talking further about them. So hypercholesterolemia, really important, but certainly something that I am personally not heavily involved with. So how do we see these conditions presenting? So with the cardiomyopathies, you may present with acute onset of severe heart failure. And my God, I've had some tragic stories over the years. And I was just thinking as I was bicycling home today of a young girl that I had, a 15-year-old who suddenly, when she got home from school, she couldn't walk upstairs effectively. And everyone thought she'd just become a 15-year-old. 2 weeks later, she needed a heart transplant. And we found that she'd got a lamin A mutation. but actually she'd had 8 weeks of symptoms, and it just got gradually more severely affected, and nobody had actually picked up her heart failure. So you really can present pretty quickly, and sometimes it seems overnight. And how many of these patients have presented and thought they have got a pneumonia? How many GPs have treated people with as a chest infection? So understandable, but actually their heart has completely failed. They may present even more seriously with severe fatal arrhythmias. And that you can see in, obviously, in the long QT and the Brugada syndrome, and also, though, with hypertrophic cardiomyopathy and arrhythmogenic cardiomyopathy. So the three main cardiomyopathies that we actually see is hypertrophic cardiomyopathy, which has an overall incidence of 1 in 500. We do not find mutations for all of those, and I will come back a little about that as well. Dilated cardiomyopathy, these are all incidents, they're not prevalence, is rarer when we're looking at the genetic form, but if you look at the prevalence of dilated cardiomyopathy, it's about 1 in 400 overall. And arrhythmogenic cardiomyopathy is the one that really, really, really worries me, because these ones have a pretty high risk of sudden death, and this often starts to occur in the teenage years and is very associated with sport. So these chaps all have had clinical screening. So we got Fabrice Muombo, we've got James Taylor, we've got Christian Eriksen, all of them presenting with extremely severe arrhythmias, all very well-known sportsmen, all will have gone through, as I said, screening, and that will all have had echocardiograms, all have had ECGs. And if anything's picked up in any of those, you go straight on to have exercise tests, MRI scans, 24-hour tapes. And I know that because I'm quite involved at St. George's with Professor Sanjay Sharma, who does a lot of sports medicine, and we have a master's in sports medicine there, which I teach on. So these chaps completely, utterly missed by clinical screening. And so I don't know if they all have genetic abnormalities. I do know some of them have got genetic abnormalities, and James Taylor has come forward, and he was known to have arrhythmogenic cardiomyopathy, and this was completely missed on screening. So I think when we start to look at hypertrophic cardiomyopathies, it's very important to separate this into two different kinds of patients. So the septal hypertrophic cardiomyopathy is the ones that you really think about as having hypertrophic cardiomyopathy. These are the young people in their teens, in their 20s, 30s, who present with symptomatic disease or serious arrhythmias. Whereas the apical hypertrophic cardiomyopathy, who have these almost more dramatic ECGs with this very widespread T-wave inversion, actually are the ones that we much, much, much less frequently identify an underlying monogenic cause. And there seems to be large play of other genes that aren't in the classical hypertrophic cardiomyopathy genes. So they seem to be almost two separate groups of disease. The trouble is, with the apical hypertrophic cardiomyopathy, there are a few patients and a few genetic diseases like Fabry's disease that can present with an apical HCM. So we can't completely ignore it from a genetic point of view, but the chances of finding a gene are much less likely. So the ECG may miss early disease. The abnormalities may not always be present. And very frequently, these patients will present and people think that they have had a cardiac MRI, a myocardial infarction. So if we look at just the physiology, and I think this is
the heart is a beating muscle that continually pumps blood to the lungs and organs of the body. Inside the heart are four chambers, two upper chambers or atria, and two lower chambers or ventricles. The ventricular septum is the muscle which separates the two ventricles. Hypertrophic cardiomyopathy, HCM, is a genetic heart disease where there is increased thickness of the left ventricle, predominantly affecting the ventricular septum. There are two types of HCM, non-obstructive and obstructive. Obstructive HCM occurs when the mitral valve makes an abnormal motion and contacts the thickened septum, obstructing the flow of blood from the left ventricle out of the heart, as well as causing leakiness or regurgitation of blood back into the left atrium. This obstruction to blood flow and mitral regurgitation creates high pressures in the heart and is the main cause of limiting symptoms in patients with obstructive HCM. Symptoms may include shortness of breath with exertion, chest pain, dizziness, or exertional fatigue. Although there is no cure for HCM, there are several effective treatment options available to improve symptoms.
So I just wanted you to see that, because I think it, although I failed to introduce it because it seemed to set off straight away, is you can see why these patients present with syncope when they take exercise. You can see how as the septum contracts, you've got no blood that is able to get out through the aorta. So exertional syncope, chest pain because there is this thickening the septum and there isn't enough blood supply to get to all those thickened muscles. And that's why these patients can be completely fine at rest. But as soon as they start exercising, you can see if they've got obstruction. And you can also see why they would get sudden death. So what about what genes are we actually looking at? And the two commonest that are actually causing hypertrophic cardiomyopathy are the beta-myosin heavy chain, or MYH7, and this other one up here, the myosin binding protein C. And this is a particularly exciting gene at the present time, because they are developing a specific treatment for mutations in the MYH7. And once again, this is a gain of function. And this little point is permanently stimulated. So the mutations are just causing stimulation of the MYH7, and it's just contracting. It's just causing contractions of the protein so much more. And up here, we've got the troponin genes, and they're also very important because they are calcium-related genes. And calcium plays such a hugely important part in cardiac contraction. So what can we do? Is there any point? Why do you want to actually identify this? Well, we know we can give them exercise advice. We keep well hydrated. There is a lot of drug treatments to limit the effects of this. There are the calcium antagonists, although they're not as exciting and useful as you might think when you look at some of the mechanisms of this. There is, and I'll come back a little bit later to some of the surgical approaches, but I have to say that is a rare need to undertake surgery for hypertrophic cardiomyopathy. ICDs, and I'll come back to looking at that in my next slide. And of course, we can undertake family screening. But this drug mavacamten, which has not yet been released, hence it's sort of slightly lower in the line, is working against the MYH7 protein. It is actually antagonizing that. So we're getting specific treatments for specific mutations. So what about using ICDs? And this is something that scares patients, it scares us. Some people love them, some people are desperate to have an ICD, others are terrified. And they can be unbelievably effective. But the real problem one actually has to remember, they do sometimes fire unnecessarily. And all of you will have had an electric shock, and it's actually incredibly unpleasant. And with certain conditions, every time you get an electric shock, that stimulates a huge amount of adrenaline to be released, and that can just release another electric shock because that puts you into another rhythm. So they are not the be-all and end-all of treatment. And this risk calculator was actually, I think it was Perry Elliott who produced this, and it sort of tries to work out who needs an ICD. And in the general population, that might work very well. But we're actually now looking at it much more with what mutation you might have, as well as other risk factors. So you're normally risk of 5 year sudden death at 5 years, 1% will say if you need an ICD or not. But actually, the genetics is now starting to influence who we give an ICD. So I think it can be quite important. So let us look what other treatments you can potentially have for HCM. And here you can sometimes, you saw in those pictures in the video, how you obstruct the cardiac outflow tract. And here you can cut through the cardiac muscle and remove some of it. Remember, you've got the cardiac conduction system coming through that as well. So people are pretty cautious about undertaking myomectomies. And the other possible form of treatment, surgical treatment, is where you get ethanol-induced infarction. So you call a septal ablation with alcohol. Again, you can have conduction problems following this, but they can really make symptomatology much better. But they need to be very, very cautiously introduced. So hypertrophic cardiomyopathy is incredibly important, very common, with over 1 in 500 of the population with this. Septal hypertrophic cardiomyopathy, much more likely to find a genetic abnormality than you are with apical, and it is in the younger population as well. So what about dilated cardiomyopathy? And I always join these together with arrhythmogenic cardiomyopathy, and they used to be very much separate. We used to have separate gene panels for both hypertrophic and dilated and arrhythmogenic cardiomyopathy, but in fact they really are very the genes so overlap that we now run them always together. But it's very useful when we're thinking about them, because there is a propensity for arrhythmias with some of these that is not present as much in others. So when you look at the amount of sporadic DCM where you will find a mutation, it's probably, so when you take a family history, lots of people have died in the past and they were put down to a myocardial infarct. And of course, I just remember as a junior doctor, everybody had a myocardial infarct. We didn't look for any of these abnormalities. Echocardiograms were only just being developed, and they certainly weren't available on a daily basis. So, you had the ECG changes that can look like a myocardial infarct. You had enzyme rises, and that was as far as you went. And I still look back and think, oh, I know how many I must have missed of these those years ago. So we identify about 50% of the underlying genetic cause when there is a clear family history. But the catch is here There are over 60 genes, but a lot of them, the evidence is actually quite poor. So one does need to be cautious what one in fact looks at. Now, the good thing is the mortality for dilated cardiomyopathy has improved considerably. It used to be 50% 5-year mortality. It was much worse than cancer. It was a really, really diabolical disease. But we have got now, more and more really good drug treatments. And in fact, I've now got quite a lot of patients for whom we now have no evidence that they've had a dilated cardiomyopathy. We keep them on treatment in most cases. And again, if there is an underlying genetic cause, then we always keep them on treatment. So I think that's another good reason why a genetic diagnosis is useful for them. So the ECG can be normal, but you might get T wave waves inferolaterally. You can have abnormal Q waves if there's extensive fibrosis. Occasionally you see LVH, not very often, and you can just see some conduction disease. So the ECG, or you may see just low voltage waves, which is what I tend to see, I think, more often. There are the biomarkers, which are probably more useful. So you get raised troponin and you get the BNP, which is probably more useful and certainly something that we follow on a regular basis. Does it predict survival? But it does come back to normal. But if it remains severely elevated, then it is a very poor prognostic sign. So what sort of genes are we looking at when we're looking for the underlying cause of dilated cardiomyopathy? And there are two genes that I particularly want to point out in this particular slide. There's this thing called lamin A, and this is another one called filamin C. And these are really, really nasty mutations associated with a lot of scar. And this one, the filamin C, supports the cytoskeleton. It sort of supports the whole cell, and lamin A supports the nuclear membrane. But if you look up here, you've got MYH7, and if you remember, MYH7 was the common dilated hypertrophic cardiomyopathy gene, and you've got TNNT2, which is one of the troponin genes. So these are really important genes in both hypertrophic and dilated cardiomyopathy. The spectrum of which genes involved with MYH7, slightly different. Some of them are loss of function when you've got a dilated cardiomyopathy. And here's our friend Titin. Titin, 2 to 3% of us will have a mutation in Titin that could lead to a cardiomyopathy. And that is a little bit of a problem, because who is going to get it? And when do we see Titin producing disease? And I'll come back to that a little bit later. But the cardiac MRI, I think, is a particularly useful investigation when we're thinking about the arrhythmic burden of a gene. So if you look at here, we can see a lot of fibrosis, epicardial fibrosis in these two pictures. And these people have a really, really high risk of having a major event. They also have a very high risk of their heart failing. So you get a dilated cardiomyopathy, but the first presentation can be arrhythmic. And certainly James Taylor, who's come forward in the newspaper to say that was his underlying problem, is he had an arrhythmogenic cardiomyopathy. Now, the other group of proteins is if you remember from your basic science, the intercalated disc is the difference really between skeletal and cardiac muscle, and the cardiac muscle binds these, the intercalated disc binds the cardiac cells all together, And if you have weakness in these proteins, you get a nasty arrhythmogenic cardiomyopathy. And desmoplakin and plakophilin here are really, really important. So plakophilin gives you right ventricular abnormalities, so ARVC, or arrhythmogenic right ventricular dysplasia, which is what we used to call it, is predominantly secondary to plakophilin mutations, whereas desmoplakin was always known as the right it was ARVC affecting the right left ventricle. That didn't seem to make sense. So now it is all arrhythmogenic cardiomyopathy. So these particular mutations, PKP2, DSP, filamin C, and lamin A, are particularly important because of their huge arrhythmogenic burden. So just summarizing the genes involved with familial DCM, MYH7, MYBPC3, not very important, titin, very important, and then this lot, ZASP, I've got to say, I don't think I've ever seen these as really being absolutely barn door mutations. Now, I just want to point out dystrophin. And for those of you who remember, this is the gene that causes Duchenne muscular dystrophy. Do you remember Duchenne muscular dystrophy? 1 in 3,000 boys. And we're seeing it more and more causing isolated cardiomyopathy. We know that there are milder forms of this where you get Becker muscular dystrophy, so you get a much later onset of disease. But this is a really important, relatively new cause of cardiomyopathy. And we just don't know when these patients present with their cardiomyopathy whether they're also going to get skeletal muscle weakness as well. And that can be difficult when you are counseling people, because you're just not quite sure what the future is going to actually look like. So these are the ones that I would like you just to remember: the lamin AC, which has an extremely high arrhythmic burden. Often you have ECG abnormalities first, probably lots of ectopics. And I remember one of the patients that I first saw, I sent him to a cardiologist. I just couldn't understand why he had so many ectopics, nor could the cardiologist, and he dropped down dead at 35. And only later were we able to find a lamin mutation. So high burden of ectopics, often no other functional abnormality at the beginning. So this is always a rather a terrifying slide of how many genes potentially are involved. Now, we're not looking at all these genes because there are many that we would really struggle to understand what they are actually causing. So these are the ones that we would be particularly interested in. And here you can see how many more are associated with titin than any of the other genes. Here you can see lamin, and you can see that there are a number of sporadic ones, and that's because they are new mutations. And I've seen more that have actually started with lamin than anything else. So I think that's a summary. This is a gene that I'm very interested in, but I know nobody else will, so I'm not going to talk about it anymore. So what about not all dilated cardiomyopathy is familial? What else should we actually be thinking about? Well, myocarditis has been very much in the news over the last few years because there is a very specific myocarditis that you see with COVID. And I was always thinking, well, I wonder if these patients are going to have underlying cardiac mutations or cardiomyopathy mutations. And I haven't yet found any, and they do seem to be recovering. And I don't know if the cardiomyopathies are going to be long-term, but I'm not aware that there is a lot of evidence that that is the case. this condition, Kawasaki disease, often you get aneurysms of your coronary arteries, which can be very important. Ischemic heart disease, Michael and I couldn't decide if to include ischemic heart disease in this particular slide, but actually it does form a cardiomyopathy, but it is certainly not an idiopathic cardiomyopathy, and it is relatively easy to separate. So that's important. Pregnancy cardiomyopathy is a very important problem, and there is certainly an increased risk of this if you have titin mutations. And we've just got one slide about that. There are, I suspect more of these are autoimmune than we actually know about. Alcohol, terrible, I'm afraid. And there are then these tachycardia-induced cardiomyopathies, but again, I'm not convinced that they are truly isolated. This is important. Anthracyclines after chemotherapy. These are, we screen everyone now having certain types of chemotherapy for a cardiomyopathy, and some of them already got problems before treatment, and you really have to be very cautious of the drugs. My colleagues at Harefield, who do all the cardiac transplants, say 80% of their patients have had cocaine, and they really believe that cocaine is a very, very powerful, well, we know it's a very powerful vasoconstrictor, and maybe a very important point of low cardiac function. So making a genetic diagnosis certainly improves our treatments. We know with lamin, they are actually now they're trialing a drug with lamin like they are with MYH7, but we put in ICDs early for lamin. In the past, they were just undertaking pacemakers, but now we would go for a primary prevention ICD straight away. Fabry's disease, we've got enzyme replacement therapy, and there are now 2 or 3 enzyme replacements. We know amyloidosis, there is effective treatments for that, as we talked about mavacamten, and there are other drug treatments coming around. So we know that with these cardiomyopathies, there becomes a sort of spectrum from asymptomatic, just a gene carrier, to very serious disease. Now, if you can pick it up at this early stage, you may be able to prevent permanent damage, which occurs when you have these really, really low ejection fractions, and it's very difficult to get back to baseline. So there is a huge overlap between the different forms of cardiomyopathy, and I think Michael really should be talking to this slide, because I'm really a little bit muddled with the difference. But calcium metabolism is incredibly important in deciding which type of cardiomyopathy that you might develop, even with very similar mutations within the gene. Now, I'm not going to talk through this because this is just another slide looking at the particular genes. Now, I mentioned peripartum cardiomyopathy. Now, this is a condition, most women, when they're pregnant, start to get a bit breathless by the end of it. And we never really are quite certain if they're truly breathless. You know, everybody worries that they've had a pulmonary embolus, but a few of these really develop such severe cardiomyopathy that they land up with a cardiac transplant within a couple of weeks of birth. To start with, it was thought to be related to prolactin, but the evidence for that is really, really pretty minimum. I've certainly seen it associated when I've done genetic testing on these women. They've had titin mutations, they've had TNNT2, troponin mutations. So there seems to be a genetic predisposition in a few of these women. So what do we do if we know that some woman has got a dilated cardiomyopathy or a predisposition prior to the pregnancy? We just do echoes during the pregnancy. We don't allow labor. We would make sure these people would have an epidural and we'd have an assisted delivery. We wouldn't insist on a cesarean, but we would make sure they had an assisted delivery and probably deliver them early. I've talked about the cancer therapy, and alcohol is very similar to the cancer ones. So what about the prognosis? Does it make a difference if you have a gene mutation? Well, the actual overall function is probably a little bit worse if you have an inherited form, but look at this. This is much more important. When you are looking at specific mutations, you know that they are going to do much worse. Your risk of sudden death, VF, really influences what treatment that you would do with those. So it makes a big difference of how you treat them, which mutation that they actually have. So I'm going to leave that slide because actually I'm running a little bit out of time. So I'm going to leave that one for the moment and go straight on to talk about primary arrhythmias, which are long QT brugada, and this condition that I'm fascinated about called catecholaminergic polymorphic ventricular tachycardia. And the only reason you should know about it, if someone faints during exercise and they come into A&E, they will have a normal resting ECG, and you can only pick up the abnormalities when they have an exercise test. So it is an important condition, but it's very rare, but 30% will be dead in their 20s. So long QT is fairly self-explanatory, that they have a prolongation of the QT interval, but many times the ECG can look normal. The QTc interval, because the QT interval varies with heart rate, can be you can work out what it should be by this thing called Béziers formula. They do give an automatic QTc interval on an ECG reading, but just beware, they can be unreliable. So a normal QT interval is, on the whole, if you've got a QT interval under 440, you are that should be absolutely completely normal. But we don't really look at abnormalities before about 460. But the trouble is, a lot of people with long QT syndrome will have a normal ECG on a number of occasions. How many ECGs do you do to exclude it? There are three main forms of long QT, with long QT1 being by far and away the easiest to pick up, because they have probably almost the easiest QT to actually pick up. These are the people who pass out on exercise and have arrhythmias on exercise, whereas the long QT2 may have problems with emotional stress. And this particular group, it's their alarm clock going off in the morning, and that would make them collapse, was one way. And so they have to turn off loud noises. You know how often one jumps when one has a loud noise? This can happen with them. And so the long QT3, the ECG, it has a much flatter QT interval than the other two. But of course, what we're trying to prevent is VF. Now, not all VF will cause death. Some of them will actually return to sinus rhythm on their own. And that is a problem if you have an ICD in situ, because they will shock you. And all that has happened is you've been shocked awake, and that is actually terrifying. So when we look at the genes that we have in this in our preventative panel, it is important that we have these particular genes that are very strongly associated with long QT. But there are various things that you can do about long QT that doesn't require you to have active treatment. So there are many, many drugs that you shouldn't take if you have long QT syndrome. And this website, this Credible Meds, is a really useful. We used to do it through CRY, but they've now got this specific website. And there is a list of drugs there that every patient should avoid if they've got long QT. There are antihistamines on it. There is antibiotics, but there are always alternatives. So I think it really is important that these patients are picked up so they can avoid the long drugs on the in that list. If you have diarrhea and vomiting and you have long QT, you become much more vulnerable to your QT interval going out, and therefore keep well hydrated. Treat this actively. Treat fevers promptly. Again, high risk for arrhythmias during those periods. There are certain sports, long QT1, swimming is very bad, and things like deep sea diving or climbing high mountains. So there are things you can do way before you need beta blockers or other treatments like cervical sympathectomy. And the ECG can often be normal, and they may only need to follow the advice above rather than any drug treatment. So Brugada syndrome is something that is a tricky one. Now, this is where you get this J-point elevation or these coved T-waves and coved segment. And it's a really tricky abnormality because we have chosen not to include this in the panel of genes that we have devised, because the treatment is really, really difficult. You can, like with long QT, avoid high risk, a few medications. You can treat fevers actively, and that is very important. But fundamentally, there is no drug treatment for it at all. And we're picking up more and more people with Brugada syndrome. Most of them, we don't find a gene abnormality, because when you go into A&E with a fever or anything, you so frequently get an ECG now, and that is the time you'll get one of these spontaneous patterns. So we at the moment do not test for this. And the other problem is SCN5A is the gene for long QT3. And we have not put that in. And again, beta blockers are not very effective for long QT3. But we're uncertain whether we've made the right decision or the wrong decision. But we think it's a bit scary. And if you're going to have a test like this, you don't want to just be left with huge fear. So if we move on to the aortopathy syndromes, the main ones are these conditions: Marfan syndrome, Loeys-Dietz, and vascular Ehlers-Danlos syndrome. Now, I'm not going to talk about them specifically, except to say that there are other genes, but the Marfan gene, that can cause you to rupture your aorta prematurely. Now, we know with Marfan syndrome that you can repair your aorta, you can follow them, you can watch them dilating their aorta, and we know at what level that you should actually replace that aorta. The problem is with some of these other conditions, you rupture at a lower dilatation. So again, knowing the underlying mutation can be very helpful to assess the treatment and know what screening you should be undertaking. Now, Marfan syndrome, most people have a phenotype, and I see endless tall, thin, lanky boys where everyone thinks they must have Marfans, and in fact, they're tall, lanky, thin boys. So most of them that we see do not have that, but these are important mutations because they, again, can manage treatment. Now, this is a condition, vascular EDS. Most people read about Ehlers-Danlos, and they only ever read about vascular EDS, which is the most terrible condition, where you get spontaneous rupture of large and medium-sized vessels, as well as hollow organs. So one study suggested during labor, there was a 25% death rate during labor if you carried a mutation in that gene. It's not that high because we manage these people very much better. But the reason I bring it up is because there is this condition where everybody thinks they must have the vascular type of Ehlers-Danlos syndrome, but they don't. And it should not be called Ehlers-Danlos syndrome at all. And I'm sure all of you have patients with this, where they get mild hypermobility, they have POTS syndrome, they have irritable bowel syndrome, they have chronic pain, they have fatigue. And this is not, as far as we know, a genetic condition, and it seems to be due to some form of autonomic dysfunction. But these are patients who are desperate for a diagnosis, and one just has to be really, really, really careful about offering anything from a genetic point of view, because whatever you find is not going to be the underlying cause of these symptoms. So who should we test with the cardiac panel? So we know with young patients, they've got potentially more to gain because they may have arrhythmias, but they've also potentially got more to lose because they've got insurance issues, they've got family issues, they've got more things they are not going to be able to do. That's good or bad because it may save their life. Older patients, you know, again, it may be very helpful to their family, but it's probably not going to make quite so much difference to them because they're not going to probably want to go off and play cricket for England or do those sort of things. So they're probably going to be able to manage the disease much more easily. I think this is useful for healthy adults who are not looking for a diagnosis like those benign hypermobility patients who I would try and avoid offering a test like this. They may have a family history for which they're worried, and I think that that's fine. So we've seen with our results more people with a family history who come forward, because that's, if you're worried about something that's happened with your family, you're more likely to have a test like that. And if you have got an underlying disease, I would have a test for that disease rather than thinking, oh, well, I can have a test and that will throw in all these cancer genes, it will throw in all these cardiac genes. I might find something extra. I think you've got to be a little bit more focused under those circumstances. And we really, really want people to discuss this test before they have it, because we really don't want people to regret the test, having had the test. So when should we test? And, you know, I think if you've got specific symptoms like we see here, you should actually be having the test that is appropriate for that disease, rather than potentially just having these particular genes. But by the time you've got symptoms, it may be too late. So it may be good that we do these tests, as I say, on healthy people. So what do you need to understand? That even if you do have a mutation, you may not develop a disease. And that can be a problem for people, because they say, well, why should I have had the test done? Because it's all it's done is worried me. And of course, that is true. But on the other hand, you don't know who's going to have a problem, and you only have to, you know, I see whole clinics of people who've lost a relative in their 20s, and then you sort of feel quite strongly that this is a good idea to go ahead and have this. So the other problem that I find much more concerning is what we call variants of unknown significance. So you find a change within the gene, and you do not know if it is actually disease causing or just part of normal variation. Now, we're getting much, much, much better at sorting this out. And there was, for many years in my earlier part of my career, I wouldn't have come near any of this testing. I'm a pretty cautious person when it comes to testing people. And I felt even clinical screening wasn't up for much use 20 years ago. But we really have changed enormously over that time. So do we miss stuff? Well, as I said, we're not looking at SCN5A with long QT3, and we are not being able to pick up anything, so everything. So a negative test doesn't give you a clean bill of health. So we are including cardiac genes. So I came along rather later to this group than Ros Eels and Gabby and Lucy, who you'll be hearing from more, but who are much more involved with cancer. So there's been more of a focus on cancer than there has been of cardiac disease. But as Ros and I always have a little bit of a joust between this, is that actually you don't tend to die suddenly of cancer, and you've got a little bit more time to treat. So I think I'm really keen on trying to prevent sudden death and also prevent advanced disease, and we often still don't pick up things until they're advanced. So concluding this, it is useful if patients know what they are being tested for. You should not just have this test with not understanding there can be downsides to the results, and understanding that just identifying a gene doesn't mean you've definitively got a disease. And this is a very rapidly changing disorder, specialty. So we are looking at 81 cardiac genes. I'm rather sad that it's been put in as optional. I think this is more important than the cancer one, but then that's very much because that's the field I am in. We have got these extra genes that are there at that sort of hemochromatosis, which is incredibly common, and that will come up. We've included the polygenic risk scores, and the turnaround time is 8 to 10 weeks with a cost, as you know, of about £1,250. What have we picked up so far? And I'm going to only look at the cardiac genes because I can't really do this group here. Titin, not surprisingly, we found this. Now, I just want you to just look at this. This is one of the long QT genes. Now, this is not a long QT gene that is going to cause long QT, but it is the one where you will be needing to avoid those drugs. So you're not going to worry these patients that they're going to drop dead. You're just going to say, avoid those drugs, and that's going to keep your QT interval normal, which could be a problem. And then we've got one that I saw the other day when they've got one of these arrhythmogenic cardiomyopathies, and I'm pretty certain this one is going to have a future dilated cardiomyopathy. So that is what I'm certainly involved with this particular group of conditions, and there are further webinars looking at other forms, and the cancer, as you can see, is the biggest group here. And I think this is one that I'm also interested in. We can now do carrier screening before people have children, which can be very helpful. And then this is something which is new. Anyway, I'm going to stop talking there because I think I've gone over my time.